Okay, I think this is Terry. We're going to go ahead and get started so we can try and stay on track time-wise. Thank you everyone for joining. This is our 5th webinar so far in the collaborative. We are going to be talking about evidence-based diagnosis of UTI. So some housekeeping. We'll go through the agenda. Please mute your phones, *6 if there's background noise. Please do not put your phone on hold as we get to hear your background music and it disrupts the flow of the webinar. We'll hold all questions until the end of the webinar, and then we do have time that we've allotted to do some questions and answers. Again, thank you. This is all of our participating facilities, and we really appreciate everyone's commitment to our webinars and all the participation. So, quick updates. I will be gone next week, so anybody that has questions or emails, if they would just shoot them to both Sarah and myself. That way, if I'm not able to answer, Sarah gets them and she can kind of turf them from there. The pictures you see are Sarah's. She just spent the last 3 weeks in Iceland, Ireland, and London. So I think she just wanted us to be a little bit jealous of her excursions.
I hope you're all really jealous because it was fantastic. But I missed you all.
Okay, over to Sarah. She'll catch you guys up to date.
Alrighty. Thank you guys all so much for those of you who have completed our quarterly survey. We sent it out in the bug that went out last week. Basically what we're trying to do is put together a quarterly report for our steering committee and for the collaborative as a whole to know where you guys are at, what you've implemented, what your barriers are, so that we can get together as a state and make the necessary changes that we need to on a statewide basis and help you guys on an individual hospital basis. So if you haven't seen that link, please let me know. It's actually going to go out. I'll send a bug as soon as we're done with this webinar. So it'll go out again today, but if you need it, just let me know. I will send it out again. We would really appreciate you guys completing this by next Wednesday, which is October 21st. The goal is to be able to put something together before our steering committee on October 28th, so we can take all this information to the steering committee and make some determinations going forward. Again, data entry. It is our last month for data entry. Our due date is October 31st, which is actually a Saturday, so probably October 30th would be a better date for you guys to aim for. Again, our baseline period is 2014, 20 cases per topic per quarter. I have sent out emails to each of our teams, so you should have received one for me letting you know how many skin and soft tissue and or UTI cases we have for you entered into REDCap that are complete and ready to go into the analysis. And I've asked you guys if you're complete or not, because not everybody's going to reach that 20 cases per topic per quarter, especially if you're a smaller facility. So if you have not completed your baseline entry, please do so. And again, if you're worried about the time it's going to take you to enter and you don't think you're going to meet that deadline, let us know as soon as possible. We don't want to go too far beyond that deadline because we do want to get the analysis going. We had a nice meeting with our biostatistician and Dr. Tim Jenkins and Dr. Heidi Wald, who will be talking a little bit later about the analysis, and we're really excited about it. So we need the data to be able to do it, to show where you guys are starting from and to be able to make improvements. This is just a little pie chart, and this is based on the ideal state where each hospital would have 20 cases per topic per quarter. If that were the case, we are 39.33% complete, and we're obviously more than that right now with 1,467 entries total that are completed. So you guys have done an awesome job. We are so appreciative of all the work you've done to get that data in. We know it hasn't been super easy, but it's going to really pay off in the long run when we have the data to show where you're at and can make the improvements. And ultimately when we get the monitoring data in and we can show how great of a job you guys have done at improving your practices. I've also sent out emails to everyone about completing each of your forms. If you guys don't click complete at the end of each form, in this section here, you'll see at the end of each form you have the ability to hit incomplete, complete, or unverified. If you don't click complete at the end of each form for each case, the case will not be marked as complete and we can't include it in analysis. So if you've received an email from me asking you to do this, please go back through and make sure that each of your forms is marked as complete so we can include it in the analysis. All right, we are getting a little bit of feedback from somebody, so please make sure that you mute your line. Just a reminder of the timeline. We're in the month of October, which came along really, really quickly this year, I feel. And again, May through October was our baseline data collection. And July through December is our intervention period where we are letting you guys get a hold of all the interventions that we're putting forward, and you guys can start your implementation and your planning for implementation. So, Heidi, are you on the line yet?
Yes, I am.
Oh, fantastic. So glad you're here. And I'm going to hand it over to Terry to do kind of an introduction for you before you get started.
Okay. So we're pretty fortunate to have Dr. Heidi Wald with us. She is Vice Chair of Quality in the Department of Medicine at the University of Colorado. She's an Associate Professor of Medicine within the, I just went over that. I'll keep it kind of short and sweet, but she focuses heavily on patient safety. She's a geriatrician, so she works with the elderly. She really cares about the quality of care that our patients receive. She's been very fortunate. We've been very fortunate to work with her, and she's put together a pretty good presentation that we'll turn over to her and let her present. The PowerPoint slides will be available after the presentation, and then we will have time at the end for questions and answers for those of you that have questions. So Heidi?
And Heidi, just let us know when to switch the slides.
Oh, okay. All right.
Thanks.
I don't have control. That's very difficult. Okay. So I'm really excited to be able to share this with you. So this area is one that I'm very interested in, have spent a lot of time thinking about. I gave a webinar, participated in a webinar on a the same topic essentially this morning for a different project on a national scale. That webinar was called The Culture of Culturing, getting rid of the culture of culturing. But what happened was, you know, in some of these, some of the feedback that we get from folks is that it's just so hard to explain to people this issue of evidence-based diagnosis of UTI. And so what we heard was that people really wanted some tools that they could share with maybe frontline staff, educational modules to try and kind of move the culture a little bit. So this is something that I put together that I hope would be something that you know, real providers and staff might be appealing to them to really think about this issue. And it's just so important because in addition to just knowing what antibiotics to prescribe and when to narrow it and when to stop it, the fact of the matter is, you know, was it indicated to begin with? And I think this question is actually much more complicated than we give it credit for. UTI, everybody knows what a UTI is, but it's not that straightforward. So essentially, I think to get into this topic, you can see my first slide is, you know, what is an infection? Which one of these clinical conditions does not belong? Right? So I have up there asymptomatic bacteria, cystitis, pyelonephritis, catheter-associated UTI, and urosepsis, right? So And we don't have audience response, so hopefully you're thinking in your mind. And you know, and if you just advance it, the answer will pop up. Sarah and Terry, great. And the answer here is asymptomatic bacteria. So all of these involve, you know, basically invasion of the bladder with bacteria, or some part of the urinary tract with bacteria. And the issue is that asymptomatic bacteria, although kind of not necessarily the normal state of the bladder, is really just a colonization and not a clinically important infection. And so that's just what I was trying to get at there. There are a variety of different types of infections of the urinary tract, but asymptomatic bacteria is not considered a clinically relevant condition. If you could advance the slide. So, how do we then know what's asymptomatic bacteria and what's not? So, we could send a urinalysis, and if you could advance, great. But it turns out that of all of those conditions, and I actually don't have urosepsis up there, but that would kind of fall into the same. Of all those conditions, a urinalysis will not differentiate any of those conditions from one another, right? You'd expect it to be positive in all of them, including asymptomatic bacteria. Next, advance, please. Okay, a culture, right? So a positive culture does not differentiate amongst any of these conditions, including asymptomatic bacteria. That's why it's called bacteriuria. It's a compound word. It means there's bacteria in the urine, right? So it's not too surprising that you'd have a positive culture as well. So the only way that you can differentiate among these conditions is symptoms. And as you can see, asymptomatic bacteria has no symptoms. Cystitis typically has dysuria, frequency or urgency. Pyelonephritis has fever, flank pain, and nausea very commonly. And catheter-associated UTI, usually fever, and then suprapubic or flank pain, usually because of the presence of the catheter, doesn't have the lower urinary tract symptoms that a regular cystitis does. And then obviously urosepsis is a septic physiology and may have positive blood cultures. So next slide, please. So now that we've gotten that straight, so let's go delve a little bit more deeply into asymptomatic bacteria. So asymptomatic bacteria was originally described in pregnant women. And, you know, in younger, healthy populations, the presence of white blood cells and bacteria in the urine is abnormal. It's not typical, but it can be a transient state. You know, you introduce a catheter in younger women, sexual intercourse is common, right? So you can have asymptomatic bacteria for a lot of different reasons. Among the people, the types of populations I've listed up here, diabetic women, spinal cord injury, patients with catheters, the elderly, and non-pregnant women, asymptomatic bacteria has been studied in all of these populations. And if you advance, please, you can see that basically treatment of asymptomatic bacteria is contraindicated in all of these populations. It does not influence outcomes, only basically exposes, kind of transiently clears the urine, and only then exposes the patient to antibiotics without any lasting impact on symptomatology, etc. So, also no impact, please go back just a sec, no impact on mortality, symptomatic UTI, or incontinence in these populations. So all of the evidence-based guidance from the U.S. Preventative Services Task Force and the Infectious Diseases Society of America recommend against treatment And the only exceptions, and evidence-based exceptions, are pregnancy and urologic surgery, because the concern with urologic surgery is that if you have asymptomatic bacteria and then you're introducing instruments into the GU tract, that you could then cause an upper urinary tract infection or a bacteremia from the kind of instrumentation in the setting of having bacteria. Okay, next slide. And then we're pretty confident that inappropriate treatment of asymptomatic bacteria is widespread, right? I'm sure, if you ever take care of patients admitted from nursing homes, this comes up all the time. But this is a study from 2009, the Journal of Infection Control and Hospital Epidemiology, 414 patients admitted to a general medicine service in 2005. So, at least half of all general medicine patients get an antibiotic, most commonly for a urinary tract infection, and some, significant proportion of them don't meet any criteria for a UTI. So this is just one example. We've just done a chart review in 6 Denver area nursing homes, and something like 25% of them meet the CDC criteria for UTI. So it's a real big problem. We're probably treating a lot of patients who just have asymptomatic bacteria in multiple healthcare settings. Next slide. All right, and this is one of my favorites. This I kind of stole from a colleague, Barbara Trotter, who hopefully will be seeing a webinar in a couple of months. But this is how we view the urine, right? We kind of like to. And this is in the sense of the biblical scapegoat, where you could, put all your sins on the scapegoat and cast them out into the wilderness, and then you're absolved. But kind of in common terminology, like if we can blame stuff on the urine, then we're done. We kind of have a reason for the patient's presentation, and we don't have to worry about anything else. And this is a problem, right? Because this results in diagnostic error, right? This is, if we scapegoat everything on the urine, then we're not looking for the right answer. And so our diagnostic decision-making, kind of process stops. And this is called anchoring bias. And if you could advance, please. So what happens is, it's super easy, right? We have a test. When we used to be able to do dipsticks at the bedside, or on little labs on the floors or in the ED, we didn't have to worry about going commission whether or not we were all certified to do dipsticks, right? You got all these pretty colors when it turned positive, and you said, "Wow, I have a positive test. It must be an infection in the urine, and let me move on to the next patient or the next problem on their problem list," or whatever it is. So, and you can advance. Great. So, just a couple words about that, diagnostic decision making. So, how do we diagnose a UTI and differentiate it from an asymptomatic bacteria? And the answer is which of these? Here I give you a list of symptoms. Which of these is not a UTI-specific presentation? The first is CVA or coastal vertebral angle pain or tenderness. The next is suprapubic pain. The next is cloudy or foul-smelling urine. The next is gross hematuria. And the last is new or marked increase in incontinence, urgency, or frequency. If you could advance, please. So, and the answer is C. So it turns out that changes in the urine appearance, including, cloudy, it has some sediment, it's a little different in color, and it smells, and color meaning, it's dark today, and it's dark urine, as opposed to, clearly having some blood in the urine, and smell are all kind of common changes in the urine, but they're not necessarily specific to having an infection. So there's a lot of different reasons why one could have a change in the appearance or the smell of the urine. could be dehydration, could be medications, it could be diet, etc. It is not considered a lower urinary tract symptom. So all of the other ones would be reasonable symptoms attributed to infection, that you could attribute infection to the urinary tract. Cloudy or foul-smelling urine is not considered one of those. Next slide. So a little bit more about this. One of the things that happens is that, a lot of the patients we're evaluating for urinary tract infection are frail elders, often presenting from nursing homes. One of the problems is we're not sure that they are reliable historians or that they present in kind of typical ways. And so we tend to have an over-reliance in those patients on constitutional symptoms, right? So we think that are non-specific. We think about, fever, delirium, or really any change in mental status. And we think about functional decline. And often it's kind of things as non-specific as a patient is weak or a patient has been falling. I'd just like to remind everyone to try and mute your phone while you're not speaking so we don't get the background conversation.
Thanks, Heidi.
All right, so moving on. Back to that slide. We're not done with it. Sorry. So the point of this slide is that none of these, in particular, changes in cognition and changes in function, and frankly, are not at all likely to represent bacterial infections, and they're non-specific is the bottom line, right? They neither point to infection nor do they point specifically to UTI, so that there are multiple reasons a patient could have decreased POs, agitations, lethargy, falls. There's no particular thing pointing you to the urine, and you may want to look elsewhere, right? There could be a medication change, a change in environment. Dehydration is very common. There's so many reasons that a frail older patient could have experienced one of those things that immediately jumping to the urine is a problem. And it's a particular problem because of the prevalence of asymptomatic bacteria in the elderly. It's probably at least a third of frail nursing home eligible elders have asymptomatic bacteria. So if you look, it may be positive, and it's really going to be hard to interpret. Do you really think that asymptomatic bacteria resulted in that patient, not eating today or falling today? And is that really a reason to expose them to antibiotics? With regard to fever, fever in the elderly, is more likely to be bacterial infection than it is in younger patients. But still, UTI is not the only reason for fever in the elderly. And so, the bottom line is these non-specific constitutional symptoms, think a little bit more broadly. Don't just jump to testing the urine. Next slide. So we have these cognitive biases, right? I talked about anchoring to a positive urine test. And while we talk about antimicrobial stewardship, increasingly we like to also talk about testing stewardship, right? So if you've got a test, and I just said it's not a very good test for infection in many populations because asymptomatic bacteria, is common, for instance, in the frail elderly, then stewardship about our testing is also important, not just stewardship about our antibiotic use. And so to address these biases that we have, and what I mean is, what happens is the clinician says, send a test just in case, and then it's positive. And you really don't think there's a UTI, but you have a positive test. And once you have that positive test, it's very hard for the doc not to pull out their prescription pad. And so better not to have sent the test at all. And the idea is to encourage people to pause before they order, and also, again, really before when they're prescribing. So the idea is don't even send that urine culture to begin with, and see if we can change the way people approach this diagnosis. So next slide. Oh, can you advance for me?
I did. Is it not going?
Mine is not advancing.
Okay.
Let's see.
Let me check my connection. Did anybody else's advance?
Oh. Yep. Yours did advance?
Okay. So is everyone seeing the two-step approach, question 1?
All right. So this is, I just want to walk you through the algorithm that is kind of, so for part of this project, we developed this like 3-part UTI guidance. The first part is this algorithm I'm about to walk you through. The second part is talks about if you are going to treat, what the empiric therapies should be, how you kind of make that decision. And the third part is recommended, suggested first-line empiric therapies. So on, but the first part is really about this pause before ordering the urine test. So the first thing we're going to ask people to do is stop when you think there's been a change in a patient's condition and you're tempted to look for a UTI, is to stop and say to yourself, does this patient have any localizing UTI symptoms? In other words, have I adequately assessed this patient for localizing UTI symptoms? If the answer is no, you stop there. Do not send the urine studies. There's no indication for it. Work up other causes and reassess. If the answer is yes, we go to the next question. And the next question is on the next slide. And here's the next slide. And then you say to yourself, could a non-UTI diagnosis account for these symptoms? And if the answer is yes, like, oh, this is, how they stopped their, alpha blocker, and now their BPH is acting up, and it's probably they stopped their alpha blocker, then great, you can reassess. You don't necessarily need to go looking for infection. And if they have something, a low-grade temp, something else, increased incontinence or frequency that you can't really attribute to anything else, then fine, then it's appropriate to send a urine culture. We actually don't necessarily encourage using the UA at all because, again, it's just not helpful. And then you'll have to make a decision while the culture is pending whether or not the patient is, you're worried enough about the patient to start empiric antibiotics or not. And so if it's just, patient having some new incontinence or new frequency, but otherwise they look okay, then I don't think, then you might feel fine just waiting till your culture comes back. However, if they're having fevers, sicker appearing, obviously you might feel compelled to start antibiotics empirically. And the key then, and we're moving now on to the, really the next part of decision making is when that urine culture comes back, you better review it and change your antibiotics in response, if appropriate. So next slide. I thought at this point it'd be useful to see how this algorithm might work in the setting of clinical cases. And these are actually cases that I have cared for here at, my hospital. So the names have been changed to protect the innocent, and these pictures are not of actual patients. So case presentation number 1. So this is Mr. M. He's an 85-year-old long-term care resident with bipolar disorder and dementia. He has a chronic suprapubic catheter. And he presented to our emergency department with a falls and a facial laceration. So he went down pretty hard. His urine had clumps of material in the drainage bag, and it smelled bad. Next slide. Okay. So what happened to him? So in our emergency department, he had a urine, and I actually have changed some details, so this is a little bit revised, but he had a urine sense, and it showed he had 50 white blood cells per high-powered field and many bacteria. And in the emergency department, he received imipenem because he had a history of multi-drug resistant organisms from a prior admission, and he was called up to medicine for admission, and I saw him in the emergency department as we were admitting him. So next slide. So what if the ED had walked themselves through this algorithm? So does this patient have any localizing UTI symptoms? In fact, this gentleman had no symptoms referable to the urinary tract. Now, certainly he had dementia, but he was able to communicate. He knew he had been falling. He was, advanced, but not so advanced that he couldn't answer questions about how he was feeling at that moment. And falls are, again, not, kind of a general constitutional symptom, I would say, not a criteria that is specific to urinary tract. And so the answer here would have been, do not send the urine studies and work up other causes and reassess. Next slide. Okay, so what should have happened for this patient? So they should have stopped at that and reassessed. What should have happened is the reassessment, right? What's part of the fall evaluation, right? Vital signs, obviously had vital signs, but unclear to me that anyone had looked at them. He had his med list reviewed, ultimately, by, once he was admitted, and a physical therapy eval, right? Falls are very kind of, have multiple contributing factors, and so we kind of kept a broad net when we're looking for falls. But what did we find? Well, we found that his heart rate was 50, that he had been started on donepezil 3 weeks prior, and a very well-described side effect of donepezil is bradycardia, and that, that was very well timed vis-a-vis his beginning to fall. And so we held the donepezil. We saw, we didn't keep him in the hospital super long to watch his heart rate come back up, but we stopped the imipenem, we hydrated him, and we got him, an assisted device for his gait and balance. So next slide, please. Great. So here's another example of a case and how to use this algorithm in clinical care, right? So this is Mrs. G. She's an 87-year-old long-term care resident with a history of a stroke and depression. And she presented to the emergency department with falls and confusion. So she was confused, but unclear that she would have met actual real criteria for delirium. She was kind of not at her baseline, but she wasn't necessarily fluctuating. She didn't have inattention. Next slide. So what happened to her? Well, she had urine studies sent. So she had trace positive UA, and they sent the culture, and that was cooking. And the CAT scan of her head was negative for acute bleed. And so she received a dose of ceftriaxone, and she was admitted to medicine. But had they used the algorithm, and next slide, to say, does this patient have any localizing symptoms? So she had nothing related to dysuria, hematuria, flank pain, suprapubic pain or tenderness, etc. And the answer, was no, do not send urine studies, work up other cause, and reassess. So let's see what might have happened to this patient. Next slide. So she had a delirium assessment with the confusion assessment method. She had a follow-up MRI because she was not clearing. She ended up with a neurology consult and also PT and OT eval. Turns out she had a visual field deficit. Again, a subtle finding of a stroke would not have been easy enough to the ED to pick it up. The trace positive UA was just a red herring. It had nothing. She did not have urinary tract infection. Her MRI showed a right posterior communicating artery territory stroke. Next slide. And this is a kind of last presentation. This is an 89-year-old female with history of abdominal surgeries, recurrent enterococcus UTIs, and rheumatoid arthritis. Again, long-term care resident. She presented with a temp to 99.5. So here we have a low-grade temp, which in this patient is significant. She's 89 and nursing home resident. She had diffuse abdominal pain, nausea, and vomiting. So, could have been kind of a pyelo-like presentation. Next slide. So what happened to her? Well, urine studies were sent. She had moderate leukocyte esterase, greater than 75 white blood cells, moderate bacteria, right? Very positive. So she ended up with fluids, antibiotics, and admission to medicine. And I think the vancomycin was because she had this history of sensitive enterococcus on prior admission. Next slide. So how would you approach this patient? So this patient might have had some symptoms that were concerning for, urosepsis or pyelo, right? She had a low-grade temp and nausea and vomiting, and so she didn't quite meet the don't go do anything. But let's go to question 2. And question 2, could a non-UTI diagnosis count for these symptoms? So low-grade temp, nausea and vomiting, and diffuse abdominal pain, may or may not be a UTI. And you could go either way on this. You certainly probably want to do both things in these boxes. You probably want to work up all sorts of possible infectious causes.
Throw that one away.
You may feel that you want to also send the urine culture and consider your empiric antibiotics. But you would probably want to be a little broader in antibiotics than they were at her initial admission, because we don't know that she has the same enterococcus alone, if this is a UTI. So next slide.
Plus, all right. How young is she?
Hi guys, we're getting some feedback. Please make sure you're on mute if you are talking. Thanks.
So,
I am.
On evaluation, this patient ended up with LFTs and a CT scan. She had transaminitis. She had hyperbilirubinemia. She had an enlarged gallbladder with stones. And she ultimately ended up with blood cultures positive for E. coli and ascending cholangitis, right? And for this patient, the antibiotic choice ended up being a poor choice if you don't really know what the source of the infection is. Probably for this patient, probably should have been covered more broadly. So next slide. So just to summarize there, with regard to the real take-home points that we wanted folks to get out of this presentation is that, to make the diagnosis of a UTI, it's really preferred that you have some symptoms that point to the urinary tract. Confusion, falls, weakness, lethargy, decreased POs, agitation. They're non-specific symptoms. And although they might be related to the UTI, they're generally not, right? They could be related to any one of the many, many things. With regard to urine tests, we want you to take home the idea that the predictive value of a urinalysis and a urine culture is poor in the acute care population, right? These are often patients who are elderly, often patients who have been instrumented, who are immunosuppressed or otherwise kind of chronically ill. And so this is, it's not a great test in those populations, not to be relied on. So do not send unless you have a high suspicion based on something that points to infection in the urinary tract. I think that's the last slide.
Yes, it is.
And I'll stop there.
Thank you so much, Heidi. We really appreciate the work that you've put into putting this presentation together. And again, guys, as Heidi said at the beginning of her presentation, this is something that she really put together for the collaborative, for all of you to use when you're presenting this information to your providers. That's a question and suggestion that we got from you guys, so we wanted to be able to make this available to you, and Heidi just wanted to walk through the presentation so that you guys know what the presentation is all about, so when you're presenting it to your providers, you're able to go through that. So I'll open it to questions for anybody, for questions about the collaborative, or if anybody has questions about Heidi's presentation. Please go ahead and speak up. And make sure your phone is not on mute still. All right. Quiet group today. Is anybody still out there?
I have a question.
Oh, there we go. Good. Okay, go ahead.
This is Dana Harper from Poudre Valley Hospital. And I agree with you wholeheartedly, all of the points that you made. We are struggling significantly with getting any kind of buy-in from our physicians to avoid doing that initial urinalysis and or reflective culture. And I struggle with how to get around it, even presenting these very specific points to them, and yet they're not receptive to changing the way they practice because their fear is litigiousness or litigation.
Yeah, and I hear that specifically about the emergency department,
right?
Because they are, that's the milieu in which they practice. So I think this is where a physician champion can be incredibly helpful. Either someone with expertise in geriatrics, who is like me, in terms of someone who thinks about frail elders a bit, because that is a population where I think it's particularly a big problem. The other is your infectious diseases specialist, and I think really just it's almost like feedback, continued feedback. So when I round, I talk about this all the time with my residents. So I'm on a service that's only patients over the age of 75. So it's in acute care for the elderly service, and my residents know that by the end of 2 days, they know that every other patient that comes up from the ED has a diagnosis of UTI, and I'm going to be stopping those antibiotics. So I think there's nothing like a physician champion to get on board and have them hone this message. The other I would say is that this presentation doesn't have a lot of the frontline evidence in it. I think doctors will be much more. If you need to kind of talk to the doctors, they like to think that they're moved by evidence, right? So I have versions of this type of presentation that point to the studies. And I think that, that can be compelling as well. But I think that, in my experience, a lot of docs, it's just so knee-jerk, we haven't really considered it. And when I go and I mention this to our emergency medicine colleagues, their jaws kind of drop. I mean, this is really radical. They have never heard about this before. It has never occurred to them that, not every positive urine, not every confusion is a UTI. And it's not that they're bad doctors. They live in a litigious environment, and they live in a very time-pressured environment. that's the way they've been trained. And so the process of untraining people and changing behavior is slow. But this kind of this decision aid has been tested in a trial, and that's the paper is cited there. Dr. Trotter, really developed this. This is based on a theoretical model that was used by that was created by a guy named Cabana about how to get accepted clinical guidelines into practice. It was really a model of behavior change that guided the development of this approach. And really, you can call it what you want. You can call it a urine culture timeout, right? Every time you're ordering urine culture to look for UTI, it's just that, do I really think this is a UTI? Why? So maybe it's making them say something on the order sheet. Maybe it's, so you have to find the levers in your, that speak to your providers. And since we haven't, we have an inpatient geriatric service, that's kind of an easy place to start. We feel that our emergency department is kind of the next place to go. And we have a nice dissemination tool in our hospital. When I train up residents, they go out to other places and they can disseminate that knowledge too. They rotate around. Not everybody has, that dissemination methodology. But, yeah. So, and when it comes to culture change, right, what's your burning platform? What leaders are bought in? What's the state of your stewardship program? Do you have a strong physician leader? I think if the stewardship program is, if there's a pharmacist lead, that's spectacular, but the physicians may need to hear it from another physician. So that's the type of thing. Dr. Trotner's original project actually provided direct feedback to teams, medical teams, where they would walk through cases of both correct prescribing and incorrect prescribing. But obviously that's incredibly resource intense to be able to pull cases in real time and then, go up and make presentations to folks actively practicing on the floor.
Thanks, Heidi.
The bottom line is culture change is hard.
Yeah.
Gina, any follow-up questions to that?
No, other than I think it's funny the physician-to-physician thing didn't even work because the ED physician told the ID physician, well, you don't work in our world, so we're not going to believe what you say.
Oh, goodness.
Yeah, well, I think certain things are going to start happening. It's not just, so some of the cases that I presented to you are they're modified from real cases. But the fact that I think if antimicrobial stewardship doesn't speak to the doc, then diagnostic error might speak to them, right? They're actually missing things because they're anchoring to positive UA, because it allows them to check the box and move on to the next patient. And I think we have had multiple cases, and we do a couple times a year a joint M&M between medicine and emergency medicine. And the next case we're doing is a case where there was a bad outcome, not dissimilar to one of the other cases I presented up there, a bad outcome because they called something that was clearly not a UTI, didn't give broad enough antibiotics, didn't adequately work up the intra-abdominal process, and the patient, had a bad outcome. And so I think, obviously we don't want those cases, but look for those cases. Work with your, quality, safety, and risk folks. I mean, I'm vice chair for quality in my department, so I'm doing case review, all the time. And when those cases come up, we highlight them. But that might be another way. You actually, for the emergency department, you made a diagnostic error here, and the patient had a bad outcome, and that actually put you at more risk than, not sending the UA.
That's really good information. Thank you.
Sure.
Thanks, Gina, for your question. Does anybody else have a question for Heidi or about anything else? Or a comment?
Yeah, I do. This is Catherine Davis from Good Samaritan. This may be opening up a can of worms, but one thing that we do here is if they do get a UA in patients that they're worried have symptoms, hopefully, there is an option for a reflex culture. Can you speak to that a little bit? And if you do support reflex culturing, what criteria do you use based on the UA to reflex that culture? Do you just look at pyuria, or do you look at positive bacteria, look at iteraces, nitrates, things like that?
Right. So there's an ID physician who is the medical director of our clinical micro lab, and she absolutely is firmly set against the reflex culture. So we don't have that option. So if we want to culture off of something that had a UA, we have to add on an order. So we don't offer that. And, you know, and her feeling is, right, because, you know, we'd be culturing everything and it's, you know, junk. So, yeah. So I don't personally have recent experience with the reflex culturing.
Is there anyone else from the steering committee on the line who would be able to speak to that or give an opinion? I don't know if there's anyone else on. Okay. Catherine, if you want to email us also with your question, we might be able to shoot it out to the steering committee and put out some more feelers to some other physicians too.
Okay, thanks.
Yeah. Any other questions? Okay. So I'm going to just give you guys some wrap up for the webinar. And again, the slides that Heidi presented are out there on box.com already. If you have any questions about them, please feel free to shoot Terry and myself an email, and we will make sure that Heidi gets those questions, and we will get you guys some answers. So hopefully you'll be able to use these slides to present to your providers. So just a reminder of our education schedule. We will have another coaching call next month, and I did talk to Terry about how the last one went, and she said it was a little rough going. So we're going to try it one more time, and we're going to do a combined call with the beginners and advanced folks so that everybody's on the line at the same time and can ask questions. And we'll start out talking about barriers to implementation and the solutions that you guys have come up with to those barriers. It sounds like there's probably a big one out there with physician engagement, specifically in the ED, and I know some folks have had some success with that, so hopefully we can get those guys on the line to share. And then we are going to have a webinar in December, and Barb Troutner, who Heidi just spoke about, is going to be presenting on a UTI topic. So if you guys have any requests for UTI topics or anything that that is just a burning desire to hear about UTI related, please let us know. We're going to have a call with Barb to determine what that topic will be in a couple weeks. So please let us know. Goals and tasks for November. You guys should be done with your data collection by the beginning of November. So we have taken off the data collection part of your tasks. Again, you're just in that implementation and planning phases for your interventions. And please do contact Terry and myself for requests for site visits, coaching calls, and or data support. Again, hopefully you're done with your data collection, but if not, we want to make sure that you get that done as soon as possible in the beginning of November. And again, contacts for Terry and myself. I think you guys all have them by now. But just in case they're here. So I hope you guys all have a great day. Please email us with any other questions you have. And thanks again, Heidi, for presenting today. I hope you guys all have a wonderful Thursday.
Thank you.
Thank you.